So this infective endocarditis, so the definition is the infectious inflammation of the endocardium. So this is there is a typical lesions always present that is known as vegetations. But even though, as the definition tells, is the infectious inflammation of endocardium, but it also in the clinical point of view, it is considered as a multi-system infection syndrome because it involves not only the cardiac tissue but also other systems of the body. So the primarily involves cardiac valves as well as the endomural endocardium, the inner surface of the heart, or the vegetations can appear when there is septal defects. Usually that the high pressure sites are usually affected. And the causative organism, the predominantly by the bacterial pathogens, but other agents like chlamydia, rickettsia, mycoplasma, fungi, even in the immunocompromised people, virus may be responsible. But the common thing we are looking is the bacterial, second common is the fungal infective endocarditis. So the first, if you look into the history of the infective endocarditis, this was recognized. The thing is, in the past years, the first recognition comes over 350 years ago by a person named Lazare Riveri. Those descriptions are on the autopsy things. So there is no imaging facility. Even before 350 years ago, there is no stethoscope to tell about these murmurs. So all these earlier descriptions are come from the autopsy finding. So in this person also before 350 years, he described a person presented with a very fulminant illness with tachycardia, and that is palpitations and irregular pulse, and he died very early in the disease. And on the autopsy he is describing that hazelnut like collection around the aortic valve entrance. So that time they don't know this is endocarditis, but later when they are reviewing the literature, they are telling this should be the first description of infective endocarditis. And later there is various physicians adding on to these findings of the infective endocarditis. In 1771, a physician named Giovanni Battista Mogagni, and he wrote a book about this clinical and pathological correlation of for understanding of disease. So there he is correlating chronic rheumatic valve involvement with aortic valve endocarditis. Then in 1806, another physician, John Nicholas Coviset, he first described the term vegetations and talked about the mitral valve endocarditis also. And next, in 1825, another physician described the term endocarditis along with its stages, like early stage, that is the edema, then colonization, invasion, and later, after healing, there is calcification. So he described the stages of infective endocarditis, that is the endocarditis stages. And later, in the physician lived between 1823 to 1864. He wrote a book that's William Senhorse Kirksey. So he the first one to describe about the peripheral embolization of endocarditis. So that another person, that's Sir William Osler. You all know about these Osler's knots in the fingertips. That is the that embolization phenomenon. So he gave a famous speech in the Royal College of Physicians regarding these clinical features, pathogenesis of infective endocarditis, and he is the one who described the term. This also described the phenomenon of Osler's not also. So likewise, the history is evolving from 350 years ago to now in the development of infective endocarditis. Next, we'll look into the epidemiology. Here, the incidence is 2 to 6 per 100,000 individual per year. But the thing is, there is two different entities. One is the clinical diagnosis. One is according to our Duke's criteria. So one study is telling among the clinical diagnosed patients, only 20% is fit into the definitive diagnosis. So there is a big gap. But as you all, we clinicians can't stick on always onto the criteria. So when the patient is presenting with features of symptoms suggestive of infective endocarditis, we have to manage them as such. And likewise the age also in early days, that in the pre-antibiotic era where the chronic rheumatic valve is prevalence in the world, that age is usually less than 30 years. But with the development and advent of the antibiotics, this is gradually becoming increase and increasing, and now it's around 50 uh, years, that 57.9 years is the mean age. So, and when we look into the children, this is usually uncommon, but the children with these congenital heart disease or septal defects or valvular defects, they can get the infective endocarditis. They can develop infective endocarditis. And the mean male to female ratio also, there is male predominance is there, 1.7 into 1. And when we look into the sides, what is the predominant? Invariably, that is the mitral valve, 28 to 45 percentage is the mitral valve alone. Next is aortic valve, 5 to 36 percentage. And there is a combination also aortic mitral, and there is very minimal percentage of tricuspid valve, and pulmonary valve is in the very, very rare situation. Pulmonary valve is usually less than 1%. Next is the what is the risk factors. These risk factors is either they will, that is the risk factors is the thing going to contribute the development of they will contribute for the pathogenesis of infective endocarditis. So there is the long list. Main things are structural heart disease, damaged valves, prosthetic valves, previous endocarditis history, long-term indwelling lines for oral hygiene and intravenous drug addicts. So the classification of infective endocarditis, for that also there is no hard and fast rule, or there is no fixed classification. So this classification can be done on various, considering various factors. One classification that was done depend on the usual progression of the untreated disease. So in nowadays, in this developed antibiotic era, we cannot classify like this, because we all are quickly treat the patients if we have any suspicion. But in earlier days, when there is no not such, in fact, um, antibiotics, so that time, that is the they were classified into acute and subacute and chronic. But the thing is, acute is in one entity, and subacute and chronic both are collectively known as subacute infective endocarditis. So this acute is present with very toxic cause, fulminant cause, and patient is very ill, and if untreated, the death occurs within 6 weeks. The subacute and chronic both are considered as one. They will present with a more slow course, like a vague systemic symptoms, low-grade fever, night sweats, weight loss. Those are the features, and here usually the death occurs after 6 weeks of development of the symptom. So another type of classification, type of the valve involved, that is the prosthetic valve endocarditis and native valve endocarditis. Native valve is the own valve without any uh, own valve of the person. And another type of endocarditis is also there, that is cardiac device related endocarditis. That is, with this advent in the cardiology, there are cardiac defibrillators, implants, and this pacemaker. So they are also for these devices are posing a risk of development of infective endocarditis in this patient. Here I'm not going to talk about this cardiac device related endocarditis, but that is a different entity. So when we look into the causative organism, this acute bacterial endocarditis is usually caused by the Staph aureus, Streptococcus pyogenes, Strep pneumoniae, and Neisseria gonorrhea. And the subacute bacterial endocarditis caused by the virulent streptococci. This is the all. So apart from these organisms, there are other organisms like coliforms, pseudomonas, coagulase negative staphylococcus, Heg group. Heg group means not a single organism. There is the 4 organisms combined to form this Heg group. That is the gram negative uh, pleomorphic organisms and the enterococcus. So these infective endocarditis caused by these organisms, it's a very rare entity and we can found in various settings also. Then next thing is the pathogenesis. The pathogenesis is, as I mentioned earlier, the risk factors will lead to the pathogenesis of infective endocarditis. So here the main factors are the non-bacterial thrombotic endocarditis, hemodynamic factors, transient bacteremia, microorganism, non-bacterial thrombotic endocarditis interaction, and the immunopathologic factors. This combined effect of these factors will lead to the development. So in this chart, you can see here there is the two things have to come. One is this, the valvular endothelium or the mural endothelium or the septal defect. So usually if it is the native endothelium or native valve, the infective endocarditis won't come in a very healthy surface. To initiate the disease, there should be always a damage. It can be a very subtle damage, but there should be always a damage in the endothelial surface to initiate the infective endocarditis process. So this trauma, the damage can be caused by the turbulent blood flow or some metabolic changes or the organism itself. They can cause this damage of the endothelial surface. So when there is the damage occurs, usually our coagulation process will be stimulated. So there is the platelet fibrin deposition. With this fibronectin and other extracellular matrix, there was a platelet fibrin deposition occurs, and this develop into non-bacterial thrombotic endocarditis. This non-bacterial thrombotic endocarditis, also known as the Lieberman-Sack endocarditis. When you are telling this Lieberman-Sack endocarditis, that usually seen in some autoimmune diseases like SLE. So those patients also will develop a vegetations, and we may think this is the infective endocarditis, but in those type of patient, that is not the infective origin. That is the non-bacterial thrombotic endocarditis. So this non-bacterial thrombotic endocarditis will develop on the damaged surface. So on the other hand, if there is this damage produced by an organism, so that organism will get adhered to this non-bacterial thrombotic endocarditis and colonize that deposition. And from this colonization, after colonizes on top of the bacteria, again the fibrin will be deposited. So this organism will be hide from the flowing blood, and this bacterial divide into that, and they will invade the adhered tissue and cause the damage, and that the mature vegetation will develop. So, but in that case, this damage is caused by other features like turbulence blood flow or the metabolic changes. So, this turbulent blood flow can occur in when there is a high flow, uh, that septal defects like stenosis or a VST, with high pressure VST. So, those times you will develop a turbulence flow, and that will damage the valvular endothelium. So, in that case, there is a non-bacterial thrombotic endocarditis will develop, but there is the transient bacteremia entity. So the mucous membrane or any other heavily colonized tissue, when there is some trauma, this organism will enter into the bloodstream. So that will lead to the transient bacteremia. Usually, this transient bacteremia will be cleared within 15 to 30 minutes. But that is also depend on our body's defense mechanism. So our body's defense mechanism is in the low side. There is high chance there is a adherence to the non-bacterial thrombotic endocarditis, and that's lead to the mature vegetations. So this mucous membrane or other colonized tissue we are considering in this our gingival tissue, and the gynecological procedure, gastrointestinal procedure, and urologic procedure. So in that case, when we are that is a number of organisms colonized, the trauma, the extent of trauma we are going to produce, that will define the amount of transient bacteremia in our body. So this our transient bacteremia is in the heavy, so there is the high chance of adherence and colonization of the bacteria on that non-bacterial thrombotic endocarditis and development into the mature vegetations. So from that vegetations, then time to time the organism will be released, and the same time these vegetations will trigger the immune reaction also. There is the immune complex formations like IgG and IgM formations also. So when there is immune complex formation, then that will go and deposit on the distal tissues, and that also can lead to the develop that some pathologic features of our features of bacterial endocarditis. So the next is the clinical features. So the symptoms, you in the one side they have put the symptoms and other side signs. So the symptoms, the invariably the fever is the most common, and that is followed by the various generalized things like chills, weakness. You can anything, nausea, vomiting, skin lesions. You can tell any clinical fever complaints the patient can tell in the symptoms of the bacterial endocarditis. For the signs only, we are going to specifically look. Apart from the fever, other common sign is the cardiac tremors. So, and the embolic phenomena, skin manifestations, and these Osler's knots, that is the painful lesions in the fingertips, the splinter hemorrhages that you look under the nail bed, and the Janeway lesions on the palm and soles. There is the hemorrhagic lesions, non-painful hemorrhagic lesions, and the splenomegaly, and other septic complications like there is a distant deposition of the that dislodged vegetations will cause the septic complications. So these are the signs. The symptom is the most common one is the fever, but the signs are the things as the clinical point of view we have to look. The fever and the cardiac murmur is the important one. The as you from that sign and symptoms you can see then each and every system of the our body is involved. That is, it was known as the multi-system syndrome because in the heart that is the starting point, that valve and the vegetations, and that can lead to the mycotic aneurysm, that is the dilation of our cardiac wall. And for the CNS, usually in the left heart, the left side of the heart is involved, the developed infective endocarditis, the vegetations will dislodge. So this septic emboli, we are telling septic emboli because the vegetation is carrying the organism. This septic emboli will take along with our circulation and lodged into the brain tissue and can cause infarction as well as the abscess formation. Likewise, in the eyes, that is mostly the immunological phenomenon. We can see the retinal hemorrhages, that is also known as Roth spots. The lungs, usually in the right side in infective endocarditis, through the pulmonary circulation, the septic emboli will lodge into the lung and can cause the uh, infection, pneumonia in the lungs. And in the spleen, there is two things: immunological reaction as well as the splenic abscess. Immunological reaction will cause the splenomegaly, and the septic emboli will cause the splenic abscess as well as the splenomegaly also. And the skin, there is the various manifestation I have mentioned earlier. These Osler's knots, Janeway lesions, splinter hemorrhages under nail bed, and the petechial rashes. So the patient may present with any of the symptoms. Only with the pneumonia, they may present with pneumonia or the skin manifestation or the stroke because of the CNS involvement. The manifestation going to be a stroke. So the fever with stroke. So the patient can present to the any department of a medical specialty. So the careful history examination and the investigation going to help in the diagnosis. So the laboratory finding, first the hematology, for the any patients with fever, we'll do a full blood count. So that will have a anemia, that is the low hemoglobin. And this, if you do the blood picture, that will give the conclusion of anemia of chronic disease because for the subacute presentation. And another thing is the leukocytosis, that is the increased WBC counts, and the ESR also increased in the chronic forms, that is the subacute infective endocarditis. And in the UFR, because of this, septic emboli will go and lodge in the kidneys, and there is the tubular necrosis, and the patient may develop a glomerulonephritis also. So the presence of hematuria going to be a feature of in infective endocarditis. And two important other another important laboratory investigation is the blood culture. So the blood culture is a primary investigation we should do for an infective endocarditis. As you all know, if you suspect a patient with infective endocarditis, we should take at least minimum 3 blood cultures 1 hour apart. But if we are in any urgency, we can take in half an hour apart in 3 different sites. So one, to decide the um, to decide whether the organism isolated is in the pathogenic one or the non-pathogenic one. That is a colonizer one or the contamination. Other thing, to catch the intermittent bacteremia present due to this infective endocarditis. So this blood culture we should take before starting antibiotics. That is the another important things, because the most common organism is virulence, and even with a single antibiotic uh, administration, we will lose the blood culture positivity. Other one is the echocardiogram. Echocardiogram, that is not the laboratory finding, but one of the investigation we have to do. That is also an important investigation. So that will directly say about the presence of vegetations. But sometimes there is dilemma about whether the non-bacterial infective endocarditis and infective endocarditis, and this some atrial myxomas, there is always dilemmas present, but with the experience only they will decide what it could be most probably. And for the echocardiogram also, there is two types. One is the transthoracic and another one is the transesophageal. Usually for the ease and less complexity, always we go for the transthoracic echocardiogram. But if the clinical features strongly suggestive of infective endocarditis, but if we cannot find anything in the transthoracic, we can go for the transesophageal, or sometime like aortic valve endocarditis, those things more easily visualized in the transesophageal rather than in the transthoracic echocardiogram test. So, in this echocardiogram, they will assess the size of the vegetations. That is the important thing for this, for our future management. And another thing, in the echocardiogram, they will tell about this our heart mitral. There is a risk factors like the stenosis. If there is development of regurgitations, those things also we get to know from the echocardiogram. The next we'll move into with these the clinical examination and the laboratory finding, the diagnostic criteria. As it told earlier, there is the modified looks criteria. So for this diagnosis, they are considering the two criterias. One is the major criteria, and other one is the minor criteria. The major criteria is the blood culture positivity. So the blood culture, we have to think at least minimum 2 blood cultures should be positive, which is the organism should be the common organism which is causing the infective endocarditis. And other one is the echocardiogram supporting there is the vegetations. So that is the major criteria. The minor criteria are, one is the predisposing factor, such as chronic rheumatic heart disease, or indwelling prosthetic valves, or intravenous drug abuses, or long-term indwelling lines. So that is the one predisposing factor. Other minor criteria is the presence of fever. Third one is the vascular phenomena. Vascular phenomena is there is the septic features, that is the septic emboli, that is the major arterial emboli, septic pulmonary infarcts, mycotic aneurysm, intracranial, Janeway lesions, and conjunctival hemorrhages. And the immunological phenomena, that is the due to the immune complex deposition, we will develop those things. That is the glomerular nephritis, Osler's nodes, Roth spots, and the rheumatoid factor positivity. And another thing, even though the blood culture we are telling, it's at least minimum 2 blood cultures, which is usually the organism defined as the uh, commonly considered as causing infective endocarditis. That's in the minor criteria also. There is a microbiological evidence is coming. They are saying positive blood culture, but does not meet a major criterion as noted above, or it's like a single blood culture positivity, like for the coagulase negative, and usually like coliforms, those things we are usually not considering as the organism causing endocarditis. So the single blood culture positivity of those type of organism, or serological evidence like some antibody, we are demonstrating the antibody rise in the antibody titers. For example, the Coxiella burnet. So that no, that is not coming. That's coming under the major criteria. For something like typhoid, we are demonstrating the development of serological evidence of infection and ASOT. So those things coming under the minor criteria. For this diagnosis, that is the modified Luke, according to Luke criteria, there is three different entities. One is the definitive infective endocarditis, possible infective endocarditis, and we can't tell, that is the rejected, that is the no infective endocarditis. There's the three different criteria coming. For this definitive infective endocarditis, that is the two. For the definitive infective endocarditis also, there is two entities. One is the pathological criteria, other one is the clinical criteria. This pathological criteria is directly we are from the vegetations, we are taking out the vegetations or some intracardiac abscess or some lesions, and by the histology or microbiology we are confirming there is the presence of organism. So if it is there, that is the definitive infective endocarditis. But we can't usually go for that. We can't take the vegetations as easy as possible. That is the difficult thing. So usually always we are going for the clinical criteria. There, if there is both major criteria are present, that is the blood culture positivity plus infective vegetations in the echocardiogram, then that is the definitive infective endocarditis. So if it is, there is only one major criteria is present, like either the blood culture or the vegetations, and we have to take three minor criteria should be present along with the one major criteria, or five minor criteria alone also enough to make a definitive infective endocarditis. And the possible infective endocarditis, one major, one minor, or three minor criteria are there, we consider as the possible infective endocarditis. So if the definitions can't fix into these things, then we have to reject. There is no evidence of infective endocarditis. But what happens is, even though it is not fixing as such, if there is strong clinical suspicions that patient is having infective endocarditis, we have to treat them as infective endocarditis. That is the final decision going to made by a clinician itself. So the last thing is the management. So the management, that is solely depend on our blood cultures. That's why I told you diagnosis through the blood culture is the damn important thing. So this, according to the organism and according to the type of valve, like native valve or the prosthetic valve, that also going to decide how long you are going to treat that patient, and according to the organism also going to decide how long you are going to treat the patient. And that organism itself will decide, and along with this native or infective, prosthetic valve will decide whether we are going to give the monotherapy or the single antibiotic or the combination of antibiotic. For example, we look a few examples. One is our blood suspected infective endocarditis. Our blood culture reveals a methicillin resistant Staphylococcus aureus. Considering the patient is not having any risk factors, there is no prosthetic valve, there is no lines, nothing. So in that case, monotherapy with vancomycin is recommended. But the patient is having a prosthetic valve, we have to go for a combination of therapy. That is the combination of three antibiotics, like vancomycin, gentamicin, and rifampicin. So if you all know, the vancomycin and the gentamicin are renal toxics. So if you combine two renal toxic drugs, the outcome going to be more risky for that patient's renal system. So when we are going to start these type of organism, the definitive diagnosis, the definitive organism causing this infection is the very important. But some instances we are getting the culture negative, that is known as culture negative infective endocarditis. So in that situation, what are we going to do? Usually, if you see the percentage, this virulence group is the common organism causing the infective endocarditis, because some people are telling even the simple brushing can lead to the transient bacteremia, and there is a subacute damage, and the organism can lodge and cause infection. So in that case, if we are having a culture negative infective endocarditis, usually if there is no other risk factors, we can start the treatment as the Streptococcus viridans treatment. But if the patient is having some risk factors like indwelling catheter or the intravenous drug abuse, then they will have the high possibility of infective endocarditis due to the Staphylococcus aureus, so the coagulase negative Staphylococcus. So those type of history, our antibiotic choice is going to depend on the going to be the vancomycin. So if there is a culture negative infective endocarditis, we look deep into the patient's history and then decide what is the antibiotic we are going to start. And I earlier in this management I have mentioned that is the depend on the organism, our choice of antibiotic and duration going to be vary. For another example is, I told you that Streptococcus viridans is the common organism causing infective endocarditis. So the Streptococcus viridans also, even if it is a Streptococcus viridans, our treatment duration is not going to be same in each and every patient, because we have to test the sensitivity of Streptococcus viridans to the penicillin. So, and divide into in penicillin sensitive, intermediate sensitive, and resistant. So according to these difference, the penicillin sensitive ones, we are going to treat for only 2 weeks. But for the intermediate and the resistant one, 4 to 6 weeks. So you understand. So for the 2 weeks, 4 weeks, 6 weeks is going to give a great impact on for the patient as well as for the hospital. So the patient have to stay for these long time at hospital, and there is risk of hospital acquired infection, cannula site infection. So we have to compensate each and everything. So you always bear in mind, if there is anything you have having a suspicion of infective endocarditis, always take blood culture before starting antibiotic therapy. That will help in future planning how we are going to manage that patient. And another thing, end of the treatment, we have to do the echocardiogram and document the finding, like calcified valves or the mitral stenosis or regurgitations. Those things should be there, because the previous history of infective endocarditis is also a risk factor for the future endocarditis. So when a patient presents again with the features of endocarditis, we can compare the previous echo at the present echo to see is there any difference is there, or it's the same presentation the patient is having this time. So the next thing is the another management is the surgery. So the surgery we are not going to do on each and every patient, and there is some certain criteria: the vegetations, valvular dysfunction, and the valve perforation or rupture. So if these things are present, that is the indication for the surgery. That usually we are telling that persistent vegetation after embolization or the more than 10 millimeter, whether it's not responding to the antibiotic treatment. And there is a cardiac development of cardiac failure, and those things are the indication for the surgery. But the thing is, the surgery itself carried a significant mortality. This is the true history I have encountered while working at TG Hospital, Jaffna, a young boy. He's also he was a university student and had the prosthetic valve endocarditis. So the even after treatment for 6 weeks of that is a prosthetic valve MRS endocarditis, even after 6 weeks of treatment, her vegetations persist. So the according to our criteria, we have to go for a surgery. But the mortality is estimated very high, and on the next day of surgery, the patient passed away. So the surgery is not a simple thing, you have to understand. So usually we have to try our maximum to manage the patient with this antibiotics. On this, it's the surgery should be reserved for as the last entity. The the last one is the prevention of infective endocarditis. So we have seen some risk factors. Some risk factors are non-modifiable, such as like a structural heart disease, or though we can't modify that. Some septal defect, those things we can't modify. But some things we can be modified. It's like if the patient is the intravenous drug abuse, we have to go for the drug rehabilitation, and the proper oral hygiene, because there is always if the poor oral hygiene and with the usual brushing, there is a chance of the transient bacteremia. And there is the presence of the CVP lines like HT catheters, hemodialysis catheters, or CVP lines for a long time. That will lead to even the cannula site infections, will lead to the infective endocarditis. So we have to remove from the unwanted lines, and we have to keep the patients free of line as possible. And this appropriate antibiotic prophylaxis. As I mentioned earlier, the pathogenesis, one is the formation of the non-bacterial thrombotic endocarditis, other one is the presence of the transient bacteremia. So this combination, to block this development of the transient bacteremia, we have to give the antibiotic prophylaxis when we are handling these highly colonized mucosal surface. That is this gingiva, the oral, when there is going to be an oral procedure associated with the bleeding, or a cystoscopy or a endoscopy associated with the biopsy taking, there is a risk of bleeding. We have to give the proper antibiotic, through that we can prevent the infective endocarditis.